I'm leader of Cheshire West and Chester Council. I'm chair of our Health and Wellbeing Board, and I'm proud to represent the residents of Little Neston and Ness. And it's just amazing to see the number of people and the enthusiasm for this agenda this afternoon. I think we've got nearly 200 people on the call, and I'm sure more will join as we go along. And I can see more people coming into the lobby and more people piling in, so that's brilliant. Today is an absolute golden opportunity to come together as partners from so many different organisations, but we've all got one shared goal, and that is to tackle inequalities. And I know that many of you will have attended the previous event that we had with Sir Michael Marmot in Chester before COVID. We're all here because we want local people in Cheshire and Merseyside to live healthy and happy lives, but to also recognise that every single one of those places across our region has inequalities, and we're here because we want to address those gaps. In Cheshire and Warrington, we've set up a sustainable and inclusive growth commission with our local enterprise partnership. And this is to act as the catalyst for a delivery of a programme that will realise Cheshire and Warrington's ambition of delivering sustainable, inclusive and healthy economic growth. Our Health and Wellbeing Board in West Cheshire recently has decided to refresh our place plan in line with the emerging priorities from Sir Michael Marmot's COVID-19 report. And what has become more challenging, and we all know this, that since COVID, those inequalities have really been amplified, and COVID has acted as a way of really shining a light on that and bringing it all to the forefront of our minds. We're in really critical times at the moment as we continue to battle COVID, but we also need to think beyond and look to recovery. There's some big changes in our NHS system as the Cheshire and Merseyside integrated care system develops from the shadow form over the coming year, and local integrated partnerships are also established. We will hear from Sarah O'Brien shortly, who is the Executive Director for Strategy and Development for the Integrated Care System. There could not be a better time to start this really important journey as a Marmot community. And this event will be followed by a series of local workshops for each of our 9 local places to help us refine our plans. We also want to tackle some key priorities together, those that will make the best difference to the people that we serve. No one organisation has all the answers or resources, and we can only really improve population health by working together. Every citizen in our region has the right to good health and well-being throughout their whole life. So sincere thanks and support for the support and expertise of the Marmot team, and we will be hearing from Sir Michael himself today, and we're honoured that he could join us and is willing to help us. Our aim is to really utilise the expertise of Sir Michael's team to help us work together as a system, inspire us to action and guide us. Our ambition is to see demonstrable change for local people as a result of this collaboration. Continuing and worsening health and inequalities are not inevitable, and we want to make a real difference. We'll also hear from 2 of our local academics, Professor David Tyler Robinson and Dr. Andy Mabala, about some of the excellent work that they've been leading, and we hope to maximise all of our academic expertise for the benefit of the local people in Cheshire and Merseyside. Before I introduce our first speaker, we have to do the usual housekeeping. So we have turned off all the facilities for cameras and microphones except for the presenters. So please, can you use the chat facility as you go along to pose any questions ready for the Q&A session later on in the afternoon. And we'll pick up the most popular questions in terms of likes. So get liking as well as posing questions, and we'll try to answer as many of the questions as possible. If you're on social media, please use the hashtag BillBackFairCM. And then we'll have a break at 3:10 for 10 minutes. So you can get a rest from the screen and have a bit of a comfort break. and it is being recorded and will be available on the Champs YouTube channel. So first of all, I'd like to introduce the first of our special guests, and I'm delighted that we're joined today by the Metro Mayor for the Liverpool City region, Steve Rotherham. I'm sure most of you know Steve. He's been elected as the mayor since 2017. He got re-elected in May with a massive majority. So well done, Steve. I'm delighted to have you here today, and over to you.
Thanks, Louise, and well done with coping with the constant interruptions as people get from the lobby into the meeting itself. Listen, first of all, thanks for inviting me to speak today, and it's great that Sir Michael has found time in what I know is an incredibly busy schedule to join us. So it shows you that he believes and his team believe that this is an important juncture for us all. I think it's safe to say, isn't it, that the last year has been the most demanding and difficult that any of us will have ever faced. I know it has been for me. The pandemic has stretched our public services to the very limits, but it's exposed many deeply entrenched inequalities across the country, which, of course, we're here to discuss today. And I know such inequalities won't be news to any of us on this call. But there are some, I have to say, especially in government, who have chosen to ignore some of those issues for far too long. So over the last year, we've had a two-tier country with people from poorer and ethnic minority backgrounds having a very different experience to those, should we say, from more affluent backgrounds. It's those same people who were disproportionately more likely to die from COVID, who were less likely to be able to work from home and are now less likely to get vaccinated. If levelling up was intended to be just a cheap election slogan, then it's about to become a very expensive public health necessity. And in areas like the Liverpool City region that are most in need of investment, we've borne the sharpest edge of austerity that characterised the past decade, and we've been disproportionately impacted by COVID. Each week throughout the crisis, I receive a briefing on COVID figures from our local public health directors, and the data which we had to fight tooth and nail to get hold of is very specific, and it drills right down to postcodes across the whole city region. And what is striking is the extent to which infection rates have corresponded to deprivation rates throughout the Liverpool City region and throughout the pandemic. In fact, if you overlay heat maps on social deprivation or high density housing, unemployment, poor wages, frontline public facing jobs, and compare those results with areas experiencing COVID difficulties, it won't be surprising to you that there will be similarities in those hotspots. So if you take Knowsley, for instance, where I grew up, it's no coincidence to me that one of the most deprived areas in the whole country, with high levels of ill health and a workforce largely unable to work from home, was consistently in the Champions League places in terms of local authorities' infection rates. And many of you will perhaps remember that the area had the third highest hospitalisation rates in Europe back in October. And so it's blindingly obvious that a postcode lottery still exists. We have a virus that may not recognise wealth or social status, but it does target the vulnerable, and it is incontrovertible that government policy does the same. For over a decade, we've had a government that has deliberately, in my opinion, underfunded deprived communities and those left behind, and therefore exacerbated existing health inequalities. In our region, we've had some of the widest health disparities in the country. And if you look at the data on life expectancy, for instance, I think we've all seen the cliched contrast between Kensington here in Liverpool and Kensington and London. But you don't have to even look that far afield for those disparities between, say, the capital and our own area to see the scale of the challenge. There are parts of our own city region, where a baby born today can expect to live 23 fewer healthy years than one born just a few miles down the road. And that's not a gap in healthy life expectancy, it's a yawning chasm. And we need real sustained action to fix it, and we need it fast. So if we're serious about levelling up, and I've got some doubts, we must start targeting resources at communities most impacted by the pandemic, and do that now. Deprivation has the potential, not deprivation, but devolution has the potential for us to close those gaps. But it has to be genuine devolution of power and resource, and not devo blame. And we saw some attempts by the Prime Minister to shift the blame back in October last year. Perhaps we can all remember those scenes, but it was as unedifying as it was unnecessary, because we've demonstrated that our area stands ready and willing to work in partnership with the government of the day, whoever they may be. Indeed, today's report by the Department for Health and Liverpool University highlights that potentially thousands of lives have been saved in our area by piloting a mass testing regime. And I'm really excited by some of the opportunities of doing that, working in the Liverpool City region, so that we can turn the tide on health inequality locally, and using, in truth, sometimes the limited power and resources that we have at our disposal. We can't do it alone. We need to work in partnership with central government. But we're in the process, for instance, of laying a 212 fibre optic network, giving us ultra fast speeds and the capacity for big data analytics. And some of you then might be thinking, well, what's that got to do with health? Well, it's because we're thinking big and ambitious. If you compare what we're doing and contrast that with what the opportunities are, it will help us deliver some of the massive improvements in public health services, particularly in the world of health and social care, with the possibilities for us to capitalise on virtual health and AI diagnosis and all of those sorts of things that really could be a game changer for us. And those things that will help us to address areas of health inequality. For instance, in our universities, we've got some world-leading institutions and academics who've done some unbelievable work over the past year to help us, first of all, to learn more about and then to fight back against the coronavirus. And we've got some really, really exciting plans to capitalise on that expertise. And I can't say too much about that now, but if you do keep your eyes peeled, you'll see around resilience issues just how much we're bringing those exciting plans into the fore. We've already allocated £5.3 million for something called a civic data cooperative that will provide us with better insights into care needs and things that will enhance data security across the many NHS and local government organisations that provide care currently. And so throughout the crisis, I've said that despite the immense challenges that COVID has thrown up, it also provides us with some massive opportunities too. And that's one of the things with the data co-op. We want to ensure that we make our country, and certainly what we can do in our region, fairer, greener, cleaner and stronger. And you'll have heard this before, but I do believe we've got a once in a lifetime opportunity to right decades of inequality. Now we just need the political will from central government and the funding investment, I'd call it, to make that happen. And I'm ready and willing to do that. Today, my question in PMQs would have been, is the Prime Minister ready to do that with us? And we'll see what we in the coming months and years, whether it is about levelling up or whether it's about levelling down. And so I'll leave it there, Louise, but thanks very much for the invite. I'm really looking forward to hearing the other contributions later on. Thanks a lot.
Thanks very much, Steve, and some really interesting points that you've raised there. Okay, so without any more delay, I'd like to move on to our next session, which is about the ambition for improving population health in Cheshire and Merseyside. And I'm delighted to have two speakers, Eileen O'Meara, who is the SRO for Population Health across Cheshire and Merseyside and Director of Public Health in Halton, and Sarah O'Brien, who's the Executive Director of Strategy and Development in the Cheshire and Merseyside Health and Care Partnership. So over to you both. I think Sarah's going first.
Thank you, Chair, and afternoon, everybody. It's a real privilege to be here and to be part of reaffirming all of our ambitions across Cheshire and Mersey to reduce health inequalities. So Eileen and I are going to do a little bit of a double act, and we really just wanted to take a few minutes to just set the scene and be really clear about the ambition of the Health and Care Partnership. And I think one of the reassuring things about the changes that are coming through the legislation is that underpinning the legislative changes is that absolute commitment for integrated care systems to improve population health and reduce inequalities. So really, I'm just going to start first to say that our ambition across Cheshire and Mersey, and this isn't new, as the Chair has already said, we started this work a couple of years ago when Sir Michael was here before, but we really want to build on the work and in particular build on the learning during the pandemic, but also recognise the how the pandemic has exacerbated our inequalities in some of our communities. But our ambition is to become a Marmot community and to become a super region Marmot community. And I think today is the relaunching of that ambition. And it is a really good opportunity to, together with all the key partners, make that commitment across the whole of Cheshire and Merseyside to tackle inequalities. And as it says there, we're going to use that joint influence to challenge those inequalities. And I do think the Cheshire and Merseyside becoming an integrated care system is another really important opportunity for us to do this. So just a little bit, and I'm sure most people on the call know this, but just to reiterate around Cheshire and Mersey Health and Care Partnership, it is the second largest integrated care system in the country. And as I'm sure you all know, it is made up of 9 local authorities and 9 clinical commissioning groups. And as we move through the changes that the legislation is coming, that's our 9 places. We do see the system, the 9 places are key components of our integrated care system. We have 17 NHS trusts and 51 PCNs. And of course, most important of all are our 2.6 million residents. And the reason all of us are here today is to have that shared commitment across the system, across all key parts of the system, to improve the lives of the 2.6 million residents that live across Cheshire and Merseyside. The size of the integrated care system does make some of this a challenge, but I think it also presents us with many, many more opportunities. I also just wanted to touch on, I've got 2 more slides around and some of this was already actually mentioned by Rotherham. I think we've got some strengths that have developed during the pandemic that we can really build on as we go into this relaunch of our Marmot work. One is that use of population health data, population health management, and we were fortunate during the pandemic to get funding to use CIPHER, which stands for Combined Intelligence for Population Health in Action, and we were able to use that CIPHER tool during the pandemic to really target testing and vaccination. And we know that there's much more we can do with a system like that in terms of really focused population health management. And we're doing some work building on in this year and testing out a new concept called System P to how we really use that data intelligence to really target some of our most deprived communities. So that is a real asset for Cheshire and Mersey and something that we really must build on and use to support the work we're going to do with the Marmot community. In addition, I think another real strength of Cheshire and Merseyside is our partnerships with our academic and innovation partners. And we've done some really innovative joint work, again, pre the pandemic and then during the pandemic with our academic partners. And we really need to build on that and make sure that we're using that research expertise and that evidence base to further make sure that the work we're doing to address inequalities does have an impact and does really reach those hard to reach communities. I'm going to hand over to Eileen now.
Thanks, Sarah. Can I have the next slide, please, Ryan? Or shall I take? I'll take.
I can move them all if you want.
Oh, right. Okay. Thanks. So, next slide, please. Okay, so if we look at a local example of what we're doing across Cheshire and Merseyside, we've started now to think about what we call anchor institutions, and anchor institutions are big organisations that can have a really big impact on the local population. And what we recognise in Cheshire and Mersey is that one of these is the NHS. So we want to start by looking with our NHS hospitals what we can do to take forward anchor institutions to think about what they can achieve. So if we move on to the next slide, what we can see here is what Warrington and Halton Teaching Hospital are doing. And they are thinking about things like reducing environmental impact, which is really important because the public sector accounts for 40% of the carbon footprint across the UK. Also thinking about buildings, how can we use those buildings, not just as hospitals, but as places for the public to use for community events. And if we think about the UK, the NHS actually has 8,000 sites. So we've got a lot of opportunities there. Following on from that, we can think about the fact that the NHS also offers a lot of opportunities for development of skills in a whole range of areas. So thinking about that, we can take that forward and offer local apprenticeships and schemes for young people to come and work with colleagues across the piece. Okay, so another area that we're looking at developing across Cheshire and Merseyside that we've started on is working with local sports partnerships. And at the moment, what we have is we have one for Cheshire and one for Merseyside. And if we bring them together, we've actually got a really big sports partnership then, which will entitle us to Sport England funding, and it will allow us to have a whole system approach to physical activity across Cheshire and Merseyside, a bit the same way as they've managed to do in Greater Manchester. And then we can think about linking that to the Department for Culture and Media and so on, and get far more people active and moving. If we look at what they've done in Greater Manchester, they've done things like Active Souls, which is about everybody wearing trainers to work and actually getting out and working during lunchtime, going for a walk. So things like that, we're looking to do that. Okay, thank you. Next slide, please. The next one going to come up? No? Okay. Well, I think the next slide anyway is the slide just from Champs.
It's up now.
The next one. Oh, here we are. Sorry, it's come up now. So the next one now is about in the economy. And what part of what we've done is what Mayor Rotherham was talking about. We've actually commissioned a wealth and well-being survey to look at what we could do to improve workplace health for Cheshire and Merseyside. And what we've found is that a healthy population is a productive population. At the moment, Liverpool City Region loses £3.2 billion in terms of sickness, people feeling ill, people not being able to work. And part of that is to do with what's in the workplace and thinking about what we can do to improve that. So we want to think about fair pay, fair hours, thinking about diversity, flexibility, and also including staff and workers in decision making. Thanks. Next one, thanks. So this is Champs Public Health Collaborative that have organised the event today. So if anybody's got any questions or wants to know any more, just let us know. Thanks. Thank you.
Thanks very much, both of you. Some interesting updates there And now we'll go on to the main event for today, which is a special address by Sir Michael Marmot. Absolutely delighted to have you here today, Sir Michael. I don't think I need to go through your very long and illustrious biography. I'll just let you use the time to talk to us about everything you're doing currently and what we can do here locally.
Thank you. Thank you, firstly, for not going through my curriculum vitae, but particularly thank you for inviting me. The work that we are planning to do with you is very exciting and very important. I'm going to start with the bad news and then go on, I hope, to better news. The Cheshire and Merseyside, you don't need me to tell you, has more people living in deprivation than the rest of the country, high levels of child poverty. And let me start exactly as you said right at the beginning, Louise. The pandemic has amplified and exposed the inequalities. So let me start with where we were before the pandemic. I produced, with my colleagues at the Institute of Health Equity, the Health Equity in England, the Marmot Review 10 years on, and we published it on the 25th of February 2020, just before the pandemic started. We were looking back at what had happened in the previous 10 years. And my simple answer to what's happened was we have lost a decade, and it shows. I hope most of you will be familiar with this by now. Increases in life expectancy for women and for men, going back to 1980, but I could go back 100 years. It was increasing at about 1 year every 4 years. And then 2010-11, there was a break in the curve and a dramatic slowing. What happened in 2010? We had a new government elected, a Conservative-led coalition government. They were a bit sensitive. They said, surely you're not suggesting it was anything we did that led to this slowdown in health improvement? Well, it's something we should look at. You had a policy of austerity. It's just possible it might have had something to do with the slowdown. One counter-argument was, well, we've got to reach peak life expectancy sometime. Maybe we've just reached the peak, and that's why it's slowed down. So we looked at other countries. This is the annual life expectancy improvement in weeks. In all of these countries, I don't know if you can enlarge that, but I can scarcely read it. And there's the UK. We had the slowest improvement in life expectancy of any rich country except Iceland and the United States. So no, we had not reached peak life expectancy. The social gradient is vital. We tend to think about health inequalities as if they're confined to poor health for the poor, and it's a convenient way to think about it. We talk about the prevalence of poverty. I talk about it myself. But in fact, inequalities in health are better represented by a social gradient. Classify people, this is England as a whole, by where they live, classify where they live by level of deprivation, and the greater the deprivation, the shorter the life expectancy. The gap between the least deprived decile and the most deprived decile was 9.5 years for men, 7.7 years for women. We can find small areas with much bigger differences than that, but for the country as a whole, between the most deprived decile and least deprived decile, it was the gap I've shown you. And that gap got bigger over the decade. The gradient got steeper. The inequalities got bigger. And it intersected with region. I'm showing you women. It looks rather similar for men. The least deprived 10%. If you're in the least deprived 10%, it doesn't much matter where in the country you live. Northeast, Northwest, Midlands, London, Southeast. It doesn't much matter. There are relatively small regional differences, and life expectancy was improving a bit in all the regions for the least deprived 10%. For the most deprived 10%, it matters enormously where you live. Life expectancy was going up in London and was going down in virtually every other region outside London. Just reflect on that for a moment. We are used to the idea that health improves all the time. And that's an evidence-based habit. Health improves all the time. And what we're showing is that for the poorest 10% of areas outside London, life expectancy went down. That really isn't supposed to happen. And the fact that it did happen is a tragedy, and we have to put it right. This is the Northeast. My geography is not skew. I know Cheshire and Merseyside's in the Northwest. I just happen to have a slide, but it's the same picture. It illustrates. This is what I said. For the least deprived 10%, there's very little difference. Then the more deprived, the bigger the difference between the London region and the Northeast region. And for the London region, the dotted lines 2010-12 and the solid lines 2016-18, life expectancy went up. For the Northeast, life expectancy went down. So the regional difference is getting bigger, and similarly in the Northwest. And all of this is pre-COVID. This was my 10-year on report. And life expectancy in Cheshire and Merseyside and the Northwest region. The red line is male life expectancy for England. And this is male life expectancy for the Northwest region and for each of the constituents of Cheshire and Merseyside. And only up here in Cheshire East, really, and Cheshire West and Chester. I don't know, Louise, whether you can take credit for that, is life expectancy longer than the English average. And for women, but for every other constituency in the area, it's shorter. And for women, likewise. Male and female life expectancy at birth by the average index for multiple deprivation. It's what we see in the country as a whole. We see it for the 9 local authorities within Cheshire and Merseyside. The less the deprivation, the longer the life expectancy for women and for men. Very clearly linked with deprivation. And healthy life expectancy, similarly, they're the English figures, and Cheshire and Merseyside and the Northwest region are disadvantaged compared with England. And that's really very important because healthy life expectancy stopped improving in England as a whole. And the gap in life expectancy, the difference between the most and least deprived decile within each local authority in Cheshire and Merseyside, here's the England average for women. The England red is the England average for men. And you can see that the gaps, I said that there was about 7.5 years for England as a whole. But you can see there are bigger inequalities within some of these areas than in England as a whole. In my 2010 review, Fair Society, Healthy Lives, reviewing all the evidence, we said, we didn't use the phrase levelling up then, but we could say to reduce health inequalities, there are 6 domains that need attention. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, healthy standard of living for all. Everybody should have at least the minimum income necessary for a healthy life, healthy and sustainable places and communities, and taking a social determinants approach to prevention. What do I mean by a social determinants approach to prevention? We heard a lot yesterday about personal responsibility. Everyone should take personal responsibility. Yep. So part of your personal responsibility should be feeding your family healthy food. It's up to you to feed your family healthy food, isn't it? Exercise personal responsibility. Well, people in the most deprived 10% of households would need to spend 74% of household income on food if they were to eat healthily. This is not a matter of personal responsibility, because the other side of personal responsibility is blame. Are you going to blame these people for eating unhealthily? It's not the individuals that are to blame, it's their poverty. Want people to eat healthily? Give them the resources so they can have a healthy diet. Public sector expenditure percent of GDP was in 2009-10, 42%. The government's stated ambition was rolling back the state, austerity, getting the public finances in order. It had different terms, and they did it, by golly. They reduced public sector expenditure from 42% of GDP year on year. So by 2018-19, that 42% had become 35%. They did roll back the state. Can you do that and not expect any ill effects? On my morning walk, I bumped into a senior economist and advisor to the Bank of England, and I said, how can you just keep cutting public expenditure? And he said, oh, they talk about efficiency. What? Efficiency? The thrust of our 2020 10 years on report is what parades as efficiency was damaging the public health. In our 2010 report, Fair Society, Healthy Lives, we introduced the idea of proportionate universalism. We said we want universalist policies. Why? Because there's a social gradient in health. If you focus only on the poorest, so this is, let's say, some measure of socioeconomic position, and this is life expectancy, there's the gradient. We want, if you want to level up, you want to improve everybody across the social gradient, universalist systems, but the need's greater down here, effort proportionate to need. The National Health Service illustrates proportionate universalism. If you have diabetes and peripheral vascular disease and renal disease and hypertension and ocular problems, you need a lot of care. Effort proportionate to need, but it's there for all of us, whether we need it or not, which is very reassuring. And when we do need it, we have it. Most of us would like to feel that we won't need it very much. It means we're healthy. So it's a universalist system with effort proportionate to need. What happened over the decade? This is council spending per person by level of deprivation. So the grey bars are total local authorities spending per person. In the least deprived 20% of areas, the spending per person went down by 16%. The greater the deprivation, the greater the reduction. In the most deprived 20% of areas, the spending went down by 32%. What we've got here is not proportionate universalism, it's effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could this have contributed to worsening health and increased inequality and life expectancy going down for people in the poorest areas? Yeah, I think that's a credible proposition. And I present this because if we're going, and I say we in Cheshire and Merseyside, I'm honorary with you, if we're going to make a difference, it's got to be in a context of levelling up, and that will take resources. I'm not going to go through all of my recommendations, but let's look at child poverty. This is England, children living in poverty before housing costs. So poverty is defined as less than 60% median income. Before housing costs in 2010-11, 18% of children were growing up in poverty. After housing costs, that was 27%. And the 27% went up to 30%. That will have damaging effects on early child development. It took a footballer to get the government to reverse its policy on free school meals, because growing up in poverty is likely to mean food insecurity. And if we look, this is from Institute for Fiscal Studies, at what happened to taxes and benefits by household income. So the red is working age families with children. If you were in the poorest 10% of household income, as a result of changes to the tax and benefit system, your income would go down by 20%. If you were in the next poorest decile, it would go down by 12%, 9%, and then the richer you were, the less the reduction. In the top two deciles, there was some reduction, but nowhere near as steep as for those much lower down. I showed a version of this graph to a former minister in the coalition government and said, your government's policy was to make poor people poorer. And he looked uncomfortable and said, perhaps that was not our explicit policy. I said, they're very clever people in Her Majesty's Treasury. They must have told the Chancellor that was the predictable effect of his policy. And average weekly earnings in Cheshire and Merseyside, there's the Northwest region, that's the English average, and average weekly earnings. So being in work is not the way out of poverty. Cuts to local government mean cuts to all kinds of services, including services for young people. Perhaps that's why, after a small dip, violence increased, and it increased the most for those in more deprived areas, least deprived, most deprived. Prevalence of obesity. There's the English average, and it's higher than the English average in each of these 9 local authorities. As you know, I talked about free school meals. that poverty is not only about lack of nutrition, it's about quality of nutrition, and increasingly obesity follows the social gradient. So that was all before the pandemic. I waited 10 years to do a follow-up to the Marmot review. We waited 10 months to do a follow-up to our 10 years on review. And we produced the report, Build Back Fairer. Exactly as you heard from Louise at the beginning, we have a social gradient in COVID-19 mortality that looks very similar to the social gradient in all-cause mortality. I was talking to a group at Oral Health the week before last, and I got data on caries in young children, decayed, missing, and filled. If I didn't label it, it would look like COVID-19. What? Caries in children is due to too much sugar and not enough fluoride. We think that COVID-19 is due to a virus, and they show the same social gradient. Yeah, the virus is involved, but COVID-19 is about the nature of society, and the inequalities in health more generally apply to inequalities in COVID-19. There's some excess down here, which we think is related to frontline occupations and crowded. But in general, if you want to deal with the inequalities in COVID-19, you've got to deal with the causes of inequalities in health more generally. And then we have the ethnic differences, the high mortality in Black African, Bangladeshi, Black Caribbean, and Pakistani, and to a lesser extent, Indian. Astonishingly high mortality compared to white. Much of it can be attributed to geography, where people live, level of deprivation, other socioeconomic characteristics. In the case of Black African and Black Caribbean, not much, in fact, none at all, seems to be explained by prior health status. But for Bangladeshi and Pakistani, some of the excess is related to prior health status. In discussing this, people talked about the importance of washing your hands, social distancing. I was asked on the BBC, what did I think about that advice? And I said, very good advice. And we should deal with structural racism. Can't see this very well. This was published yesterday by the Health Foundation. This is excess mortality. In other words, in comparing countries, not looking at COVID-19, but total excess mortality. And I'm pointing, if you can see my pointer, to the UK. And in the early part of the pandemic, we had the highest excess mortality of any country. Looking at the US, their management of the pandemic was a disaster. Our excess mortality was worse than the United States. And here we are in a late stage. Spain and the US are worse than us, but we're right up there with high excess mortality. We had, before the pandemic, the slowest improvement of any society except the United States and Iceland. And now we have the highest excess mortality of any country except the US, any of the rich countries except the US, and in fact, in this case, Spain. And that's interesting. Again, this is from the Health Foundation's report yesterday. If you look at the healthy life expectancy improvement, 2010 to 2019, and excess mortality, the slower the improvement in healthy life expectancy, the higher the excess mortality in 2020. So in other words, what I'm describing for the UK, that we did pretty poorly coming into the pandemic, and very poorly during the pandemic, is a general phenomenon. The more countries improved in the decade before the pandemic, the lower their excess mortality during the pandemic. So in speculating about this link, I suggest this stalling life expectancy, inequalities increasing, life expectancy for the poorest people falling, which was the slowest slowdown of any rich country except the United States. And then the highest excess mortality in the early phase of the pandemic, and asking myself, what's the link? Poor governance and political culture, increasing social and economic inequalities, the reduction in spending on public services, and we weren't very healthy. And then when we look at COVID mortality in England and the Northwest and local authorities in Cheshire and Merseyside, this is males, and in every part of Cheshire and Merseyside, the mortality is higher than the England average, except in Cheshire East. And similarly for females, that's the female figure, it's, well, there we go, one more. In general, the mortality in the Northwest and in Cheshire and Merseyside from COVID-19 is higher than the English average. But as I've been saying, that is a manifestation of inequality. And here we have the age and sex standardized COVID-19 mortality by index of multiple deprivation. The greater the deprivation, the higher the mortality. And it's only up here at the lesser levels of deprivation do we see lower than the England average, but a very steep social gradient. As you may have noticed, we produced a report for your neighbours on the 30th of June. Let me skip for a moment. The front page of The Guardian, I sent this to a friend in the United States, and he came back and he said, looked at the two items on the front page. He said, yep, the drop in life expectancy really was jaw-dropping. So is England 2, Germany 0. It's not that I'm uninterested in that one, but this is what I, forgive the cliche, this is what I described as jaw-dropping. 1.6 years decline in life expectancy in 1 year. That's enormous. That's enormous. 1.2 years for women. And the national figures are pretty frightening. And that's what I described as jaw-dropping. That's enormous. We are in serious trouble. And I work from the proposition that the health of the population tells us something fundamental about the nature of the society. And if health's getting worse, society's getting worse. If health inequalities are getting bigger, inequalities in society are getting bigger. That's jaw-dropping. I'm not suggesting we will do the same with you in Cheshire and Merseyside as we did in Greater Manchester, but we produced a Build Back Fairer framework for Greater Manchester. We had 6 pillars: future generations, exactly as Mayor Rotherham said at the beginning, it will take resources, standards for healthy living, institutions, monitoring and accountability, and greater local power and control. As you heard at the beginning of the afternoon from the Mayor and leaders, it is absolutely vital that this not be done from London. that this be done from Cheshire and Merseyside, that local power and control is important. That will take resources which come from London. But if, and it's a big if, there's any seriousness behind the ambition to level up, we've got a program, we've got a blueprint for Greater Manchester. We want to do that for Cheshire and Merseyside. Public health local authority allocations that's the England average, in the 9 local authorities. One of the problems is this, that public health spending reduction in real terms went down. And North East, West Midlands, London, East Midlands, the Northwest that was the England drop. Now, I think the health of the public is about the things I've been talking about: early child development, education, employment, having enough money, healthy and sustainable places. It's not only about organized public health, but organized public health has a vital role to play. You can't do it without a properly funded public health system. And in Greater Manchester, we developed 24 Marmot beacon indicators as a way of monitoring. And as we work with you, we'll want to look at whether these beacon indicators are the right set of measures. I hope they will be, as they are for your neighbour, for Cheshire and Merseyside. We've already heard from the Mayor of Liverpool what I think is absolutely vital, which is it's possible to look at what's going on in an area with great deprivation, great poverty, compare Kensington in your part of the world with Kensington in London, and look at the differences and say it's all hopeless, it's all terrible, and there's not much can be done. But there's a great deal that can be done. And that's the excitement I get from listening to the Mayor, listening to leaders of councils, of public health from Cheshire and Merseyside. Real excitement about what can be done. And one of the questions is, what can the integrated care systems do, the health and care partnership? And when I spent a year as president of the World Medical Association, we produced a report, Doctors for Health Equity. What can doctors do? And I would generalize it to what can an integrated care system do? Education and training, working with individuals and communities. So it's not just about delivering healthcare or social care, but more broadly, tackling the social determinants of health. We said then health sector as employer, but as you've heard already this afternoon, I would expand this to say anchor institutions, the impact on the employees, but on the local community, on purchasing, the social value of purchasing, working in partnership, which is absolutely vital, and working as advocates. It's possible to be pretty miserable about what's going on. When we were doing our PAHO commission, I wandered in Washington, D.C. in the mall and came across this quote from Martin Luther King, who said, "I believe that unarmed truth and unconditional love will have the final word in reality. This is why right, temporarily defeated, is stronger. Is stronger than evil triumphant." He's a preacher. I'm a scientist. My language is less flowery than his. But I believe with him that unarmed truth, telling the truth, looking at the evidence, can make a real difference. And it can be done with love, with optimism, with enthusiasm. I used to go around the world describing myself as an evidence-based optimist. A Brazilian colleague said, "Michael, let me teach you English. You're not an optimist, you're hopeful. An optimist believes things will get better. Someone who's hopeful hopes that things can get better. And my hope is that by working together, we change the trajectory. We work in a spirit of hope. And that's why right temporarily defeated is stronger than evil triumphant." Thank you.
Thank you very much, Sir Michael Marmot. And I love that unarmed truth and unconditional love and hope. I think that's really, really important. And I think it's something for us all to think about, that we are going forward with hope, that we can make a massive difference. It was really inspiring. You've created lots of chat in the chat box, which we shall pick up later during the Q&A time. And that point you made about individuals not being to blame, it's poverty, it's their poverty that puts them in the situation that they're in, is something that we need to hang on to, because that blame game is all too prevalent, I think, in our society, and we need to fight back against that. So thank you so much for that, and we're really looking forward, I'm sure I can speak on everyone's behalf, of working with you and your teams over the coming months. And just really a word on Cheshire West. It does look good. The overall picture does look good, but actually our lovely green leafy borough hides massive inequalities. And we find that in some places just within a mile, there's life expectancy differences of between 10 and 12 years. So it's almost that hidden inequalities that you know, we also need to think about, and rural poverty is a really big thing, and I think that's sort of something that's come out during the pandemic as well and shone a light on it. So I can't take any credit for life expectancy in Cheshire West, I'm afraid. We've still got a lot of challenges ahead, and it isn't getting any better. I'm delighted to introduce our next speaker, who is Professor David Taylor Robinson. And David is going to talk to us about the importance of protecting children from poverty and adversity based on the research that he's done in this area. Thank you, David, and over to you.
Great. Thanks very much, Louise. Can you hear me and can you see the slides? Excellent.
Yes to both.
Super. So it's thank you very much, and for the invite. It's great to be here and to be able to talk about the early origins of health inequalities. Liverpool, Cheshire and Merseyside, a good place to start when we think about how to address inequalities, because we've long been affected by stark health inequalities. This is some of the first data showing average age at death. In 1843, if you were in the labourer and artisan class living in Liverpool, average age of death 15, compared to 55 if you were gentry and professional in Bath. And if you look below one of our great cathedrals, you can see the mass graves in St James's Cemetery from the boys and the girls' orphanages. And you can see the age at which those children died, driven by high levels of infant mortality. And around about the same time, William Farr set up the system for death registration in England and Wales, and simply looking at the difference in mortality across strata, he calculated that 65,000 excess children's deaths were lost unnecessarily each year in England. And this is what he wrote in an official government statistical report. He talked about the annual sacrifice of children's lives. He wrote, "The children of the idolatrous tribe who passed them through the fire to Moloch scarcely incurred more danger than is incurred by children born in several districts of our large cities. A strict investigation of all the circumstances of children's lives might lead to important discoveries and may suggest remedies for evils of which it's difficult to exaggerate the magnitude. Work like this set in train social reform, but we still live with these stark inequalities. And today, in the next half an hour, I'm going to argue that many of the problems we face are because we've failed to prioritise child health in policy. So I'm going to talk about the early origins of health inequalities and how exposure to poverty and adversity influences health over the life course. I'll then talk about the UK policy experiments, 25 years of investment and then disinvestment, poverty falling and then rising, and the natural experiments that have been conducted as a result of that, and then talk about what needs to be done. So this is from our Due North report. You can see the north-south divide in life expectancy for males and females. You can see the green fields of the south, the blood red of the north of England, such that if we go with the cliche and contrast the Kensingtons, if you take the life expectancy of a lad born in Kensington in Liverpool and contrast it to the life expectancy of somebody born in Kensington, one of the most affluent areas, there's a 10-year gap in life expectancy, almost a 20-year gap in healthy life expectancy. We know these inequalities were getting bigger pre-pandemic, and we can say something about these differences. There's nothing natural or predetermined about these differences. They're a consequence of how we choose to structure society. Secondly, they're profoundly unjust. They demand action across the whole of society. Thirdly, we can do something about them. They're not inevitable. Through the organised efforts of society or integrated care systems, we can do something about these inequalities. And the differences show us what's achievable to some extent within a particular context. What causes these inequalities? Well, we know that they're due to inequalities in the distribution of the main influences on health, as shown here in the Whitehead and Dahlgren rainbow. You can go further. What causes inequalities in the distribution of the main influences in health? And to be clear, in our Due North report, looking at the north-south divide, we said that the drivers of inequality in health between the north and the south, within Liverpool, within the borough of Kensington and Chelsea, they're due to differences in exposure to poverty, differences in power, resources needed for health, differences in exposure to health-damaging environments, protective health factors, protective conditions, and especially the conditions that give all children the best start in life, because these inequalities start early. Here are some graphs from over the last few years. This is infant mortality plotted against child poverty for local authorities. Every blob is a local authority. Here are the usual suspects: high child poverty, high infant mortality. This is a similar graph showing children's development at age 5, early child school readiness. You can see that there's huge scope to improve development of all children, but also that it's related to levels of poverty. And here's a plot showing obesity at age 10 as children move towards adolescence, again plotted against child poverty for local authorities. An amazingly tight relationship. And we see these social gradients across all important outcomes for children early in life. This is our analysis from the Millennium Cohort Study at age 7, so it's representative of the whole country. See the gradient in mental well-being in children, evident at age 7, but also in overweight, long-standing illness, unintentional injury, and asthma. Now, we know from years of social epidemiology the processes that drive these inequalities. This is Finn Diedrichsen, who developed the Diedrichsen model that underpinned, I believe, Sir Michael, the theoretical framework for the Commission on the Social Determinants of Health. Broadly speaking, this shows the processes. So if you're born poor, you're more likely to be exposed to adverse material factors, psychosocial stresses, adverse behavioural pathways that lead to poorer health. And then as a result of poorer health, you have differential consequences depending on how rich you are, whether you lose your job or not, subsequent impacts on income. If you live in a country with no universal healthcare system, if you're sick because of poverty, you fall further into the medical poverty trap. We've written about these pathways with regard to children. You can have a look at this review if of interest. But here's a model kind of adapting the Diedrichson model. So children who are born poor are more likely to be exposed to adverse material conditions. We know that children growing up in poverty have worse nutrition, they're more likely to be hungry, they have a less stimulating early learning environment, less access to books, computers, school trips. Their homes, their neighbourhoods are noisier, more crowded. The air they breathe is more polluted. The roads that they live by are more dangerous. And we know that they're also more exposed to adversity, to family turmoil, to violence, to separation from their families. And it's this accumulation of multiple adversities, environmental adversities linked to poverty, that makes it particularly pathogenic, the most pathogenic exposure. And we know now a lot about the biological mechanisms by which poverty gets under the skin through impacts on children's brain development, through early organ function. Okay, so I've asserted quite a few things there. Let me show you some data. This is a study we did with Danish colleagues. Let's hope we beat the Danes tonight, but they beat us in terms of data linkage and in terms of conditions for children. So we were interested in looking at how life events and socioeconomic conditions for children influence adult health outcomes. And in this study, we looked at the whole population of Danish children, a million kids in Denmark born in the 80s onwards. And because of data linkage there, we were able to precisely every year look at various factors that influence children's lives. So we looked at material deprivation, we looked at stressful events in the family, parents dying, for example. We looked at aspects of family dynamics, so mental health diagnoses, parental drug, alcohol abuse, etc. First of all, do these adversities cluster by socioeconomic conditions? Yes, poorer children are more likely to be exposed to multiple adversities. And then we did a group-based trajectory modelling exercise to categorise children's experience of these adversities up to age 16. Let me talk you through this. So here in this column, you have children, 50% of the Danish population have low levels of the major adversities. Here's a bunch of kids, 20%, who are transiently exposed to poverty in early life. Here's a bunch of children, 13% in Denmark, persistently in poverty. Here's a group with high levels and increasing levels of threat or loss or loss in the family. And here's a group of children, about 5%, with high levels of all of those adversities. And we then followed those children up from age 16 and did a survival analysis, looked at the kids' risk of dying from age 16 onwards. This is the group with this is the background population with low levels of all of those adversities. Here in light blue, if you're transiently exposed to poverty around the time of birth, you're 50% more likely to die in early adulthood. Here's the group in persistent poverty and with high levels of threat or loss, double the risk of dying as in early adulthood. And here's the high adversity group, multiple risk factors. These children 4 to 5 times more likely to die. This is all playing out in the Danish registry data. And what are these kids now become young adults dying from? Well, the things that you'd imagine in this age group: increased risk of suicide, accidents, also cancer. And what this study shows, it's the first of its kind to look at this in a whole population. It shows what we already know, that childhood is a sensitive period, that even fleeting exposure to poverty impacts health. And we looked at mortality, the tip of the iceberg. We know that there's a substantial public health morbidity burden underlying that tip of the iceberg. And it's worrying for countries like the UK, we're seeing these effects in the Danish population, where they have a strong welfare system. So childhood conditions have a profound impact, cast a long shadow over the rest of the life course. Good evidence linking early life factors to a whole range of wicked problems and inequalities in those problems. So now let me turn to the UK policy experiments. So we were meant to have gotten rid of childhood poverty in 2020. So in 1999, the government says pledged to end child poverty. We've written about this in this book, if you're interested in, with contributions from Gordon Brown and Jacinda Ardern. But the poverty reduction was included as part of the English inequality strategy, regarded as the world's largest experiment in tackling inequalities. And it involved an integrated approach across government sectors, involving targets, progressive resource allocation, area-based regeneration, the establishment of Sure Start, getting rid of child poverty through the minimum wage, child tax credits, etc. In Liverpool, I was training in public health at the time. And what did we invest in? We invested in trying to tackle the inverse care law, proportionate universalism in prevention with the children's centres, with tackling smoking cessation. There was a focus on the wider determinants of health, Liverpool Healthy Homes. There was a focus on anchor institutions, on using the purchasing power of major employers to boost employment chances. And to cut a long story short, analyses led by my colleague Ben Barr and Margaret Whitehead have shown that looking at longitudinal data, that trends in inequalities before, during and after the strategy showed that the strategy had an impact on reduction of inequalities. Let me just show you this plot here. This shows rising inequalities for men in the period pre the strategy, decreasing during, and then a kick up subsequently. Another analysis has shown a similar thing with infant mortality. The targets were around infant mortality and life expectancy. So integrated strategies can make a difference to inequalities, but then very quickly hard-won gains can be lost. So we wrote that the gains of the past were being undone as, following the recession and the austerity programme, there was an abrupt halt to the progress on addressing inequalities. As with child poverty was predicted to rise as a result of changes to the welfare benefit system. This was the IFS predictions. Children were particularly targeted as a result of welfare reform. And as we know, this happened at the same time as these very large budget cuts to local government that support action on the main influences on health. So this was our analysis in 2011, Rachel Gosling, looking at the percentage budget cut plotted against deprivation. This was Liverpool at the time, top right here, most disadvantaged local authority, biggest cuts, systematically greater cuts in the north compared to the south. Here's the same data plotted against levels of child poverty and as cut per head of population. And we've done a lot of work putting together this spending, different budget lines. So in our place-based longitudinal data resource, you can access the data on spending. This shows spending on prevention for children, showing overall average reduction, 50% reduction, spending on prevention for children, much bigger cuts in the most disadvantaged areas. This is the most deprived quintile in red here. So this is Yoko Ono opening the £1 million investment in a children's centre around the corner just from here at the school where John Lennon went to. My daughter's somewhere in the crowd there, and it's been massively challenging to sustain the children's centres infrastructure in Liverpool. Although we've managed to keep the centres open, funding has been dramatically cut. And at the time we wrote that these policies represent a collective failure to protect the rights of children. And so as you would imagine, with deteriorating, with these changes, we then began to see a deterioration in some of the upstream determinants of health. Food poverty, admissions related to malnutrition started to rise. We went on to look at what was driving the rise of food bank use. Food poverty just wasn't a thing 15 years ago. And now Now over 1 million people using food banks every year, almost half of those every year, families with children. We know it's got worse over the COVID period. We did a similar analysis looking at the rise in homelessness. So creaking upstream determinants of child health happening at the same time as poverty rising. This is our latest analysis showing poverty by index of multiple deprivation, showing in places like Liverpool very high levels of child poverty. I think it's the highest in the northeast at the moment, almost 38% of children living in poverty, and it's predicted to rise. The policy response to all of this was to suggest that was to scrap the child poverty targets. So child poverty targets were scrapped, and replacement targets were suggested based upon measures of things like unemployment, family breakdown, parental behaviours, conflating, we argued, the causes and consequences of poverty. And we contributed to this all-party parliamentary group report looking at the impact of welfare reform on child poverty. There were many dissenting voices. Kitty Stewart at the LSE did a review showing of the evidence that how income matters for child health, has a causal effect on children's health. And we did a number of analyses using the Millennium Cohort Study. This is one of the papers showing what happens to child mental health and parental mental health when families move into poverty. And we showed that moving into poverty, all other things being equal, damages children's mental health, and it's partly mediated, explained by an impact on parental mental health. Just turning to our latest analysis, which will be out shortly using the Millennium Cohort Study, we did something similar to the Danish paper that I've described. We categorized children's experience of adversity, different types of adversity in the Millennium Cohort up to age 14. And the most important clusters and the most harmful clusters of exposures to adversity for children's health are shown here. So 23% of children in Millennium are always in poverty up to age 14, relative income poverty. 12% of families experience persistent, children live in households where there's persistent parental mental health problems. 11% have both. And so overall, 40% of families affected by poverty and/or mental health problems. And then we relate those trajectories to health outcomes for children. They're bad for all of the exposures, are bad for all health outcomes. But here you see the impact of that cluster of poverty and parental mental health problems on risk of children developing mental health problems. Odds risk increases 6 to 8 times. And in that analysis, we conclude that interventions to address specific childhood adversities may not be meaningful if children's socioeconomic conditions are not considered. So determinants of children's health deteriorating, then we start to see impacts directly on child health. The Royal College report in 2017 showed widening inequalities. We wrote about child health unravelling in the UK. As infant mortality, there's an unprecedented increase in infant mortality. In this analysis, we show how rising infant mortality was influenced by rising poverty. About a third of the increase in infant mortality attributed to rising child poverty. Another canary in the mine has been what the effects that we've seen on children, looked after children being taken into care. This shows Devara Bennett's analysis in our group of the dramatic rise of children taken into care, increasing inequalities in children taken into care at huge expense and cost to them and over the life course. Paul Bywaters has done this review recently, pointing out that there's a lack of joined up thinking about in terms of action on poverty and child abuse and neglect in the UK. And there needs to be widespread recognition of the link between family circumstances and the risk of children being abused, neglected, and subsequently taken into care. And indeed, our analyses show this. This is just data from Liverpool showing the rising number of children taken into care in Liverpool. And this is an analysis from our PLDR looking at spend. So over the period 2010 to 2017, across England, we've seen a huge rise in spending on looked after children and a huge reduction in spending on prevention. And of course, those two are related. Our analyses show that prevention spend is related to, cuts to prevention have caused children to be taken into care. And we've got an analysis looking at the impact of changing levels of poverty on changing levels of children being taken into the care system. It's likely that these changes are fueling child welfare involvement in England. And just finally, this paper was published not long ago looking at childhood obesity and showing widening inequalities in childhood obesity at age 5 over this period, and showing the effect of cuts to Sure Start on obesity in children, one of the modern epidemics of childhood. So some research there showing the impact of these austerity measures on the next generation of children growing up in Liverpool. And so when we look at the picture for children in Liverpool, we see a large, this is pre-COVID, we see a large chunk of the population with poor outcomes in early life. And as I've outlined, these track through to explain the poor outcomes for adults that we see in Liverpool. And it's absolutely critical that we understand the link between the two. The link hasn't been missed by the international community. I was quite taken by this report in the New York Times in 2018, which focused on children in the Northwest and how they were being impacted. The Lancet said, Britain is broken, poor child health proves it. And we were visited by the UN. Philip Alston said that poverty is causing misery in the UK. Ministers are in denial. He called it a disgrace and a social calamity. And then, as Sir Michael has pointed out, although I'm focusing on children, then we also began to see stalling life expectancy, rise in life expectancy pre-COVID. Pre-COVID, life expectancy was going backwards for women in the poorest areas. Life expectancy going backwards for women is not a good sign in terms of child health and the intergenerational transfer of inequalities. We've got a paper out, which will come out in the next few weeks, showing how central government funding, cuts to central government funding have partly explained the stalling life expectancy story. There's a plot from that analysis. So pre-COVID, we outlined that we've seen rises in child poverty, homelessness, food poverty, a deterioration in mental health. These have occurred at the same time as a reversal of investment in public services, biggest cuts in the most deprived areas. It's time to acknowledge the elephant in the room, the underlying causes of these trends, and to design appropriate policies to reverse them. And then we're hit by a global pandemic. And as Sir Michael has outlined, although the pandemic's caused by a virus, the inequalities it generates have social causes. Crises, we know that crises of any sort, disasters, epidemics, lay bare social fault lines. And so it's no surprise to anybody working in inequalities that mortality is mapped on for COVID, has mapped on to pre-existing inequalities and has accelerated them further. And it's been disastrous for children. We've seen rising poverty, toxic stress. I've described the impact of toxic stress on lifetime outcomes, rising poverty, toxic stress in families, disruption of services in education, health, social care, layered on a system that was ill-equipped to deal with demand pre-crisis. And particularly concerning is the rise in mental health problems that we've seen. This is the NHS digital data showing a 6 percentage point rise, 16% of kids have mental health problems, a rise of 6% from the last survey, nationally representative survey in 2017. What needs to be done? It's been very glass half empty thus far, but it's also a glass half full situation in that things can change. In the States, the Biden American Rescue Plan has signed into law action on child poverty that will halve the level of child poverty in the US and address all sorts of other inequalities. Premised on evidence, based on the evidence from the likes of Heckman, showing that investing in the early years is the best investment. And this report on the impact of child poverty on the American economy, suggesting it costs 1.1 trillion per year in the US, and it's much, much cheaper to address child poverty than to deal with the consequences. We have global governance in terms of the Sustainable Development Goals that are all very sensible. Number 1, zero poverty, all about inequalities. And our COVID recovery report for the North again pointed out that the productivity gap that we've heard between the Liverpool City region, 30% of the productivity gap between Liverpool City region and the rest of England is due to ill health. Ill health has its origins in childhood, and reducing this gap would make a huge difference to our economy. And we already know what to do about inequalities in the context of a crisis. Margaret Whitehead always points out that the central focus on children has been there from since the Black Report over 40 years ago. A pithy summary of what systems need to do, based on our review for WHO, came out last year. Act early, act on time, act together, local systems, particularly focused on reducing poverty. And Sir Michael's reports have outlined that giving every child the best start in life is the highest priority recommendation. This was echoed in our Due North report, where we said we need to tackle poverty, economic inequality, focus on children, and share power and resources over decisions locally. So agencies in the North can increase spend in the early years, focus on reinvigorating the children's centres. We suggested that areas should sign up to a charter to protect the rights of children to the best possible health, focus on collecting better longitudinal data. We've been able to do some of this. As some of you will know, we've got funding from the Wellcome Trust to set up a new birth cohort in Liverpool, children growing up in Liverpool, underpinned by the data linkage that we've heard about already, SIPFA, that's been used really well throughout the COVID period to evaluate the impact of some of the interventions. Liverpool's signed up to become a UNICEF child-friendly city. That's about embedding children's voices in decisions at a local level, and it's great to see that that's written into the Liverpool city plan, a commitment to listening to children and young people. And when surveyed about what makes them happy, children and young people continually emphasize the importance of being loved, safe, listened to, and while they don't deal with finances directly, they stress the importance of well-funded services and family finances necessary to meet basic needs. So clearly there are things central government need to do. We need to focus on reducing child poverty. And as we've heard, Marcus Rashford, and the issue about the £20 uplift to universal credit is absolutely critically important at the moment. That will finish in September unless there's intervention. So I think there's a huge amount we can do to improve the developmental trajectories of all children in Liverpool City region. And there's a huge opportunity. It'll improve lives for children and reduce inequalities for adults. It's baffling to me as a child public health doctor that we let an exposure as toxic as poverty wash over a third of the children in Liverpool. Thanks very much.
Thank you so much for that, David. I think it's left us all in a state of shock looking at the comments in the chat. It's caused quite an emotional response, and I think one of the points that I noticed earlier on was children don't vote, and you know, this has made my determination as a leader in Cheshire West to really want to do something. We can't go on, and you know, looking back at those statistics makes me realise what could have been, but we are where we are, and I think it's how we work together to address those to make a better lives for our children. It's our responsibility. I think. So thank you very much for that. Okay, our next presenter is Dr. Andy Mabala from Chester University. So good to have one of our academics on board. Andy, I'd like to hand over to you now to do your presentation and talk to us about your findings. Thank you.
Good afternoon. Thank you very much for inviting me to this meeting. My name is Mzwandile Andile Mabala. I'm a professor of public health epidemiology at University of Chester, and I'm also a South African tribal man. I have spent the last 5 years or so talking to and interacting to people with homeless issues. I've learned from these interactions that growing up in poverty, living in fear of strangers kicking and spitting on you in the street, begging for food, life expectancies of 43 to 45 years are not personal choices. I've learned that these are the choices imposed upon them by their social circumstances. These are the choices imposed upon them by the society and social institutions that create and sustain inequalities in health. I've learned that people who experience homelessness are amongst the population groups that experience the harshest form of inequalities. Globally, homeless people are poor. So poor, in fact, that they carry all their possessions in their bags and in shopping trolleys. They have a limited life opportunities and much diminished life expectancy, as you have heard from the previous speakers. Continuing exposure to poverty create various adverse social conditions that increase the likelihood of experiencing homelessness. These include exposure to traumatic early life experiences, social advantages such as poor educational experiences, being raised in disruptive families, care homes, foster homes, physical, emotional, sexual, and neglect at early age. In the context of our work, we define adverse childhood experiences as traumatic events or circumstances that occur before the age of 18. Several of 10 adverse shown below occur simultaneously or at different stages of childhood. Homelessness is caused by wider structural and specific individual working in concert. Individual factors are associated with individual circumstances or behavior that could increase a person's vulnerability to becoming homeless. Adverse childhood experiences are typically the example of these individual factors. Homelessness is the structural causes of homelessness is associated with the policies and social institutions that create and sustain conditions that cause homelessness. The example of such conditions includes uneven distributed, inadequate or absence of low-cost houses, unevenly distributed educational opportunities or employment opportunities, unevenly distributed income support, and benefits and social benefit. At the University of Chester, the Department of Health and Social Care, we spent the last several years looking at investigating the causes of homelessness, looking at the fundamental determinants of homelessness. Our latest project looked at 152 homeless people in Chester, in Crewe, in Liverpool, and in Manchester. We wanted to document the clusters of adverse social conditions amongst the homeless people in the Northwest. We analyzed our data using chi-square goodness of fit, Ben-Ferroni correction, Kramer's V, and two-steps cluster analysis. The mean age of our population sample was 39. The male were more male than female, and living conditions were the street, hotels, temporal accommodation, B&B, and accommodations that were provided to them during the pandemics. 86% of our participants smoked. 80% used drugs, and the common drugs they used were marijuana, cocaine, heroin, and spice. 61% of our participants described their health as poor, and 69% reported that they've seen a doctor in the last 6 months. Our study showed that having a parent with criminal record was a high predictor of becoming homeless, followed by the parents with care history, parent with child neglect, or a history of abuse. Our study showed that in terms of the frequency and the cluster of homelessness, sexual abuse, inappropriate sexual behavior, emotional neglect, physical abuse, physical neglect were amongst the most predictors of homelessness. In terms of the immediate factors that lead to the homelessness, a two-step analysis, chi-square and post-hoc test revealed that the most significant factors that lead to becoming homelessness is alcohol dependence, eviction to youth criminal activities, loss of job, and being imprisoned. We decided to develop a model to conceptualize our results. Our model shows that all participants did not have a permanent home. Our participants lived in the street, hostel, hotel, temporal accommodation, and accommodation provided to them during the COVID-19. Our analysis detected 19 observable indicators of social conditions amongst homeless people that were significantly different from the general population. 14 of those adverse childhood experiences, and 5 of them were adulthood maladaptive behavior. When we compared our results with the similar studies in homelessness, there was a consensus that most of the adverse childhood experiences have their roots in poverty, as the previous speakers indicated. We drew on the work of Townsend to define homelessness, or to define poverty, that is. Townsend defined poverty as individuals, families, and the group in the population can be said to be in poverty when they lack the resources to obtain the type of diet, participate in activities, and live in conditions and amenities which are customary or are at least widely encouraged or approved in a society within which they belong. If their resources are so seriously below those that commanded in average individual or families that they are in fact excluded from ordinary living patterns or customs and activities. This is a definition of poverty that informed our research. We decided to draw on work of Sen to understand the moral harm of poverty. Sen argues that the moral harm of being poor is that poor people lack the freedom to fully participate in social goods such as housing, employment, education, social services, and health services. As a closing remark, both rich people and poor have a freedom to sleep in the street at night. But the rich people choose not to take advantage of this freedom. Homelessness is a tragic condition that is as a result of different causes, both structural, which is political, social, and economical, and individual, which is addiction, mental health, unemployment, and traumatic life experiences. Poverty and homelessness are deeply intertwined because there is a high prevalence of poverty amongst the homeless people. The interventions that support people to rise out of poverty may therefore also reduce the entry to poverty, to homelessness, that is. Poverty set a chain of interaction amongst the social conditions that increase the likelihood of unfavorable outcome. Homelessness is at the extreme end of this interaction. Poverty is the cause of homelessness. Just to acknowledge people who made or who contributed to this project. Thank you very much to the organizers for inviting me, and thank you for the audience to listen to my presentation.
Thank you very much, Andy, and it's really interesting. I've just got one question. Somebody's put in the chat, when was your research done? What was the period? Because I know certainly from our perspective in Cheshire West, homelessness has really increased. It's a massive issue for us. So just wondered when your research was done.
We started just before the pandemic, just before Christmas 2019, and it stretched during the course of as you can see, some of the participants were reporting that they were given a accommodation during the COVID-19. So the last data collection ended at the time when we're at the period of unlocking the country around summertime last year.
Okay, thanks very much. Okay, we're going to have a Q&A session now. So could I ask our panel members to turn on their videos so we can see your lovely faces? And I'm actually going to start off with a question that's just come up now, which is probably the one I was trying to, from all the chat, bring together, but it's from Esther, and it said, I wonder if Sir Michael could detail how he envisages the status of a Marmot community, how that plays out at a local level within our communities, and what have outcomes been in places such as Coventry that has worked well, and how can we bring this into our work locally? So I think that's a good starting point, and then we'll take some more questions as we go along.
There's a negative and a positive reason for wanting to act locally or regionally. The negative reason is if central government isn't interested or is going off in a different direction, then we can't wait. We've got to act. So that's the negative reason. The positive reason is it's where people live and work. It's where, as we've been hearing, their children grow. That's where it all happens. And it's something I learned in Liverpool when we were doing the original 2010 Marmot review, and I came to Liverpool, and I went to a meeting of various community groups, and they said to me, "We do not want an outside expert telling us what to do." And I looked around and thought, they're talking about me. Nice introduction. And so I said, okay, you want to do your thing, regardless of whether it's effective. It's more important that it be yours than it works. Is that what you're telling me? So now we had a standoff, me and 200 feisty residents of Liverpool. And so then they said, okay, you tell us what the evidence is, but let us figure out how to do it our way. That sounded to me like a really good model. We take evidence from wherever. If I wouldn't be involved in global health if you needed the evidence from every particular country, because it doesn't exist. We take evidence from wherever we can find it, provided it's high quality evidence. What you do with that evidence is crucially dependent on local circumstances and local ways of doing things. So there's a very positive reason for wanting to act locally. And I don't need to tell people in Cheshire and Merseyside, what you've got is something that's irreplaceable. Pride, cultural connections, a real pleasure in place, that can't be replaced. That's very valuable. Now, exactly as Andy was saying a moment ago, you can have all those things, but if you're in deep poverty, that's going to damage your children. It's going to cause all sorts of problems. But you've got a lot to build on. And let me say one, forgive me for ranting on, but let me say one more thing. Remember, the fifth of my 5 things that doctors could do, or health and care service integrated services could do, was advocacy. A few years ago, I was invited by a SALAR in Sweden, the Swedish Association of Local Authorities and Regions. And they're really enthusiastic about action on social determinants, equity. And then I went to the Swedish Parliament and talked to their social committee. And they were a bit cautious and not wanting to do anything and weren't doing much, even in Sweden. And I said to them, you know, I was talking to representatives of 280 local areas and regions in Sweden. And if you, as a central government, don't act, you're going to get left behind. You'll find every local authority in the country is acting, and you're the only ones who aren't acknowledging what needs to be done. So what you can do is change the world. Not alone, but if Greater Manchester, Cheshire and Merseyside, north of Tyne Combined Authority, Coventry, the deprived seaside towns in the southeast, and the like, all say, we really want to do this, but it will take central government action. We can't do it on our own. Well, sooner or later, the unconditional love and the truth will win out. And the last part of your question about Coventry, yes, the indicators in Coventry are promising. They seem to be moving in the right direction. So there's a great deal that you can do regionally, locally.
I think that's really interesting about what we can do regionally and how we can come together to make a difference, because I do feel at the moment this government isn't acting in the best way it could be, and I don't want to be political here, but and that's sort of a few of the questions have been, how can we work together as a region, different regions coming together. And I know in the local government association, I believe collectively they're coming together, even in some of the areas you think perhaps wouldn't be, and there is more of a coming together in terms of addressing health inequalities. So thank you for that response. Now I'm going to put you all on the spot now before I'm a bit more specific. What is, and it's sort of come up in the question, what is the first thing that we need to do to start taking some action? Because there's been a lot of chat about, okay, we've talked about this for a long time. What action do we need to do next? And I'm going to start with you, Sir Michael, and then I'll go around each of the panelists to say what you think is the first thing that we need to do.
We will, I hope, give you an answer to that question in a few months' time. We're delighted to be working with you, and we want to do it in partnership. That's why we're doing the work. To go back to my experience of Liverpool many years ago, if we came in and said, this is what you need to do right now, then that would somehow defeat the whole purpose of working in partnership. So, and let me anticipate, we will, I'm sure, be saying it's more than one thing that's needed, but we're delighted to be working with you. Where I mentioned North of Tyne Combined Authority, we're also going to be working with Cumbria and Lancashire. So, you know, there's northwest, northeast parts of the country working together. Really, I think we can make a difference. So I'm not going to give you the answer of one now, but watch this space. We look forward to our joint work.
It's sounding like it's becoming the Marmot North, isn't it? Maybe we need a breakaway country and call it Marmot Land. Okay, so Andy, I think do you want to come in next, and then I'll go around the rest of the panelists. One thing that we can do.
I'm afraid I'm going to have to say two things that we can do. The first thing that we could do is to address the immediate effects of poverty in those population groups that are affected. I think the starting point is, I'm going to concur with Sir Michael that we need to start providing a good experience to at early age, providing good education to our children, good education experiences to our children. Those are the things that we can do in immediate terms. But there is a long-term thing here that is fundamentally all these experiences. If we look deeper in all these adverse experiences, as David indicated, as Michael indicated, it comes down to poverty. So if we invest in communities, we will be in a good direction to address the poverty, because public investment has got a potential to address the fundamental problem, which is poverty.
Yes, no, that's great, Andy. I really agree with that. With public investment. Someone's put a comment here. If we do become Marmot Land, can we join with Scotland on their trial of universal credit for everybody? Universal income, rather, for everybody. And I think that sounds a really good idea. So I'm going to ask Eileen next to come in.
Thanks, Louise. I think what we need to do is join forces. We need to all get behind, changing things and agreeing what we're going to do. And it has to be a real joint effort, because I think if you want to go alone, you go quickly. But if you join forces, we might move a bit more slowly, but we actually have a chance of changing things and making it sustainable. But we all need to really commit to it and become an army for change. That's what I'd like to see. I'd like to see all of the different sectors come together and really agree what we're going to do and make a, start to change now. And I believe we should start with children and young people. Best start in life. Thank you.
Thanks, Eileen. And I like the idea of an army for change. That's really important to show our determination and coming together with one aim and one goal. And I'm happy to be part of that army, I have to say. Can I now bring in David? There's been a lot of talk about children. I would, personally make sure we had Sure Start centres in every community. I think they're amazing, but unfortunately we've managed to keep ours open in Cheshire West. We actually reopened one, but I think we could do with some more. So David, one thing, please.
I think somebody said in the chat, this has happened on our watch: stalling life expectancy, infant mortality rising, cuts to services for children. I think, as Sir Michael has outlined in some of his latest reports, there's an issue of governance here and leadership. Do we need more reports? We've had reports coming out of the kazoo since the Black Report, all saying similar things about redistribution, investment in children. I guess one of the questions is why we've failed to do that, and I think that's an important empirical question. I think showing leadership as we establish the integrated care system, embedding principles of health equity at its centre, an aggressive focus on children. 7 million quid, that's what we need to increase the funding for children's centres in Liverpool to its peak. This is small fry in terms of what we've spent on things like mass testing, for example. These are small sums of money that we can control locally. So clearly there's not just one thing that we need to do, but I think it starts with leadership and what underpins how we move forward and how we recover.
Thank you. Sarah?
Yeah, I mean, mine was really what Eileen and now David have both just said. I think, we're waiting obviously for the Marmot work, and we know there's lots of things, some that are difficult to do, some not, but it's about making this our absolute top priority in everything we do, and making sure it goes back to the leadership thing, that particularly in the next few months as the ICS evolves and there's going to be a lot of process and governance and things, that we don't get distracted by those things away from what the true agenda needs to be, which is addressing inequalities and particularly children. So it is back to that. Every single person on the call needs to go away and, in wherever they've come from, sprinkle this and spread this out, that this has to be a priority. And it relates to a question that went in the chat earlier. The legislation will allow an opportunity for genuine place-based partnerships, and if each of our 9 places makes this their top priority, that should help to focus some of those difficult decisions about where we put the resources, about those local communities and what do they need most. So it's making sure in each of those 9 places that this is the agenda that is front and foremost all the time.
Thank you. And yeah, I think there was something in the chat about us how we all need to work together, and I suppose there is a tendency sometimes to fall back into our silos and get, my inbox is often filled up with people because they're worried about grass not being cut, but actually, this should be our main sort of focus. So I think my next question, and I'm going to throw this out to all of you, is about how we connect with our communities so they understand, because I don't think it's just about us, it's about every single person that lives in this region. And during COVID, we've seen a mass coming together, support, mutual aid, supporting each other. So how do we communicate with our communities to make sure that our messages are getting right the way through, so that people start to worry that there's children who live around the corner that haven't got enough food, rather than their bin didn't get emptied this week? So I suppose that's my next question about our communication. How do we involve our communities with this? And that Sir Michael talked about that sense of ownership at the beginning, and us not doing things to people. So I'm going to start off in backwards order now. Sarah.
I mean, again, there's not one approach, is that, Louise, you know, it's about, there was lots of chat about engagement. It's about respecting every single member of our community and having an equal, you know, partnership and relationship with them all the way through. But another thought I had, if you look at young people and what they feel passionate about, it's the environment. I often think we should use our young people to mobilise that army or that social movement. And I think we need to, maybe through our schools and our young people, educate them to poverty and inequality and get them passionate about it, because it's mainly our young people who are driving the environmental agenda and challenging. They're less interested in some of the other political agendas. So I think similarly, I would almost target our young as well to be part of that social movement and that fairness in society. And how do we address this?
Thank you, Sarah. David?
Yeah, I'm going to echo what Sarah said. Child-friendly cities with UNICEF, it's been so edifying hearing how progressive the children and young people are. And if you look at progressive agendas around the world, New Zealand, what they're doing there, Health of Future Generations Act in Wales, you ask children, they're concerned about the environment in which they live in, they're concerned about mental health, they're concerned about decent services, places to play, education. What we've been said, and Steve Reddy in Liverpool has been leading the Child Friendly Cities programme, and we need to respond to what children and young people are saying. I think there is an asymmetry of information. We don't provide, when you show children the data on the extent to which their services are being cut and the extent to which it's impacted their health, they look at the adults like they've gone mad. I think it's a really powerful lever, engaging the children in these things.
Thank you, David. So next I shall go to Eileen.
Thanks, Louise. As a result of the funding that we've had for COVID, we've decided to put quite a bit of that aside and distribute it throughout the communities so that people who have ideas about how they want to improve things for their community, for the health of their community and the well-being of their community, can then start to do that. And it's amazing. People have come up with all sorts of ideas, you know, little pots of money. People have managed to do great things. And I think it's all about trusting people, listening to people and going with their ideas, but also putting a bit of investment into it as well so that they're able to do that, so that it's not all centralised. It's actually very community-based. And that has been really popular for us, really good outcomes. So I would support that. Thanks.
Thank you. Andy?
I agree with all the points that previous speakers mentioned. That we ought to start from children. But the point that I think we also need to take into consideration is that when it's try to understand why people feel why people are disengaged, because if there is evidence that if people feel marginalized, they lack freedom to participate in activities of society. So we need to understand why is it that people are not engaging, what matter to them, and engage them and give them hope that and a sense of belonging to the community, rather than being marginalized in the community where they belong.
Thank you, Andy. In Cheshire West, we've had 2 poverty truth commissions where we listen to the voice of lived experience. And I think, you know, as we go forward with that, we need to make sure that for me, that lived experience voice is there at the heart of everything we're doing. So Michael, we are coming to the end of this section. So I wondered if you'd like to comment and perhaps sum up about what next for us?
Yeah, thank you. Three comments. Firstly, if people working in local government don't know how to communicate with the public, there's something terribly wrong. So I should imagine that's your core business. That's what you do. But it's vital. Second, I said when we had a conference, the one in February the 25th last year, to launch our 10 years on report, and I said, I think that I and my colleagues, we have done a terrible job in communicating social determinants of health, the whole concept, to the public. And somebody in the audience got up and said, I disagree. I mean, he didn't disagree that I've done a terrible job. He disagreed that the public don't get it. He said, I work with community groups and they understand this completely. They know about difficulties raising children. They know about problems with housing and making ends meet. They may not think those are health determinants, but they certainly know about problems in their lives. So mutual learning. We need to learn. The communities that we work with need to learn. We need to learn from each other. The third thing, and it relates to what you said earlier, Louise, throwaway comment of saying you don't want to make this party political, and I agree, I don't either. I've, over the last little while, had some dealings with Conservatives, Lib Dems and Labour politicians, so cutting across, I want whichever government is in power to do the kinds of things we've all been discussing this afternoon. And I briefed the shadow cabinet, and one shadow minister said, we're nice people and we've got good ideas. We're not very good at communicating them to the public. What should we be doing? And I said, one of the things that comes with age and experience is realizing which things you're no good at. And I would be terrible at advising you how to communicate with the public. I can tell you what I do, which is tell the truth, present the evidence, and engage people in the discussion about social justice and health, the moral dimension of what we're doing. Tell the truth, present the evidence, and engage the population in the moral dimension of what we're doing. And I hope that that will inform the work we do with you in Cheshire and Merseyside.
Thank you, Sir Michael. Telling the truth. We all need to go forward in our army and tell the truth. I think that's so important. And sometimes the truth is hard to cut through the untruth that's sometimes out and about. But I think if we're all determined and we have that one truth, then there is a way forward. So that now draws.
I'm sorry, if I could just add one.
Yes, go on.
We're doing a summer course this week, and I get very exercised. One student asked me in the discussion, what about if they present their facts and we present our facts? I said, no, absolutely not. There are facts, there are truths. They're not your facts and my facts, there are facts. There may be different interpretations of the facts, and we can have a decent discussion. If you're a libertarian, if you're a socialist, we can have a decent discussion about the implications of the facts, but there are facts. Tell the truth. We know what the child poverty level is in Cheshire and Merseyside. That's a fact. We know what the homelessness figures are in Cheshire and Merseyside. They're facts. We may differ on our interpretations of what to do about them, but let's work on those facts, the reality of people's lives. And that's why I say tell the truth, have the evidence, and engage people in the moral discussion.
Thank you. Lots of nodding round our panel. So I am going to draw this to a close now. First of all, thank you as panelists for your thought-provoking discussion. It's been extremely stimulating. I think everybody is going to be determined in that army going forward to take this forward. And I think some of the key points that I've sort of come out of this is about how we come together. And I think the Directors of Public Health and the Population Board will be working on that ambition going forward, and working with you at that place level, because I think one of the next steps is going to be our Marmot workshops at place level in terms of what do we need to do in this place to make that difference. So I'll look forward to doing that. We're really lucky in Cheshire and Merseyside. We've got so many assets that we can be proud of, particularly natural assets. And for somebody who's very keen on natural assets, I'd like to think about how we can include those in our actions going forward, our green spaces, our rivers, our coastlines, our urban parks, our rural landscapes. And I think for me, one of the things I've got out of today, and it's been really quite an emotional experience, is how everyone is determined to make a difference. And I think this is our time now. We've talked about this in the past, and if we don't grasp this opportunity as we come out of the pandemic, it's not going to happen. So thanks everybody for attending today. We've done an awful lot of talking, not just in this session, but over the last couple of years, last few years, and now is the time for action. And I'd like each person, as they go away from today, to think about what is that action that I need to take as an individual to help us come together to drive it forward as a region. And thank you very much to everybody who's presented, to Sir Michael Marmot, to Eileen O'Meara, Sarah O'Brien, Andy Mabala, and Professor David Taylor Robinson. And thank you very much to Champs for arranging this, and to all the people working away in the background whose face we haven't seen. Thank you for making this happen today, and hopefully see you all soon. Thank you and good night. Have a good afternoon and evening. Let's hope England win.